Hello and welcome to GBMC's Greater Living. I'm Mary Beth Marsden, and over the course of the next hour, we are going to be focusing on men and men's health. And I think we're going to be hitting, the big three health issues: stroke, heart disease, and cancer. But first, we're going to go to one of our favorite guys, Don Scott, who's going to take us to GBMC's NICU to talk about a very special event coming up.
The Neonatal Intensive Care Unit is a special place at GBMC. One where highly trained physicians, nurses, and other healthcare professionals care for the tiniest and sickest patients with around-the-clock care. I met with Dr. Maria Payne, neonatologist at GBMC, to find out more about this renowned program.
10% of babies that are born typically will go to the neonatal intensive care unit. So about 400 infants are served in this neonatal intensive care unit.
Okay, let's see what they see.
Okay.
Hello.
This atmosphere here now in this brand new NICU is really conducive to a calming environment and very welcoming for families, and we appreciate our families and the patients that we can take care of. So we'd like to involve them in the care and in learning more about their babies. The nurses are really great about education and making sure that that parents really feel comfortable as their baby, their tiny baby, or even their large baby is growing and getting better, that they feel like they can make that transition from here to home, and that's key. The goal is to get home. We have individual rooms for all the families, and that's brand new. And it's really nice because it is bright in here, but we are able to dim the shades because we like to have times when it's quiet and where they can get that day-night environment. So these shades can come down.
And how is this room different from a normal hospital room? Obviously, it's for babies. But.
Right. So this is an intensive care room for an infant. This is a special warmer for infants. So when infants first come to the NICU, they may need to get evaluated on a bed such as this. A heater comes on when this is turned on so that babies can be evaluated. Tiny babies, because we take care of babies that are even less than a pound.
Wow.
They cannot go on a warmer such as this to stay because they'll lose heat rapidly. So they'll go into a specialized isolette called a giraffe isolette, and that puts heat and humidity in that their skin, which is where you lose your most heat, stays stabilized by the temperature and the environment of that specialized isolette.
Is that what we laymen would call an incubator?
Yes, exactly. If a baby was in need of the operating room, because there are babies that need surgery, this can be taken directly to the operating room. You'll maintain temperature. Actually, if you feel it, you can feel the warmth. It's on. We're ready for that next baby here.
Warm, yeah.
The side comes down also. Most of the time, though, we don't want to release too much heat when we're taking care of the baby. So we will just gently open up these side doors, and then we're able to go in and do an exam. But the nice thing is I can see what I'm doing.
Each room features a kangaroo chair designed to promote skin-to-skin contact and early breastfeeding, thanks to generous donations from the community.
So the baby is put up against the parent's chest, and the mother or father, we have a lot of fathers doing this also, will have that baby feel the parent's warmth and then also listen to the heartbeat and the breathing. And we do encourage parents to speak to their babies. Mothers can also breastfeed them in these chairs. They can sleep, but these are graciously donated.
So if it reclines, it's easier for the person to hold the baby close?
Yes, absolutely, and more comfortable for mother and for baby, because it's very important for the parents to have comfort, but these are very specially designed.
The new unit also allows clinicians to focus on each infant's individual needs while facilitating communication, bonding, and integration with the family.
There's a computer behind you, so The nurse can be in the room, or the physician or advanced practitioner, entering orders, doing their notes, but they can also be outside of the room, and the way these rooms were designed, exactly, there's a window there that they could see, and so parents can have, you know, some privacy, but yet still the nurse can be able to see what's going on in the room. We have a specialized drawer here that's a refrigerated, so if the mother pumps milk, she can pump right in here in the privacy of this room, place her milk bottles in here until we're able to put it in a specialized maternal milk room that we have.
You've mentioned that a lot of the equipment and things are donated to the NICU, and big part of that donation thing is the upcoming Father's Day 5K. How does that work, and why is that important?
Well, the Father's Day 5K is an annual event. Can you believe we're up to our 31st event? We raise much needed funds for a lot of the equipment that I've shown you today, Don, and also for different programs, educational programs for families, for our staff. It's really our major fundraiser of the year, and a nice way, too, for our families to come back. They come back with their babies. A lot of families do the actual 5K. Some of them are in their with their jogging strollers. But it's a reunion for us.
Very good.
They come back to see the nurses and the doctors and the respiratory therapists, the social workers, I mean, the entire team.
And we're expecting another big one this year.
We sure are, and I understand we'll have nice weather, so anyone that would like to come out this weekend, Sunday, 8 a.m., starting gate, we'll get going.
Not a runner? That's okay. There's also a 1-mile fun walk and a wellness village with good food and prizes. So come on out to GBMC's campus this Sunday and support the little guys that need it most. For GBMC, I'm Don Scott.
Thank you to Don. And of course, those little guys will grow up to be big guys who maybe sometimes don't always take care of their health and focus on their own health the way they should. So that's why in this Father's Day month and in Men's Health Awareness Month, which this is, we are going to focus on men. And we're going to break up our segments in the next hour, focusing on stroke and cancer and heart disease. So joining us now is Dr. Tosin. I have to say the full name because I got it on the first try. Thompson. Tosin Thompson, thank you, doctor, who's a neurologist at the Center for Neurology at GBMC Health Partners. And thanks for being with us.
Good to be here, Mary Beth.
Yeah, so we were talking while we were watching the piece about the NICU, and we were talking about men and their health. And just overall, I know it's a stereotype, and I wanted to kind of rush right in as like, having a man that I love in my life who isn't always the best about getting the well visit or getting the checkups the way he should. Is it a stereotype that men don't take care of their health, or is it actually you see it all the time?
That's a loaded question. That's a tough one to start with, Mary Beth. I would say it seems, I certainly see more women in my clinic, concerned about their health. But I would say the good news is that, over the years of my training, I see more and more men come, unprompted, so to say.
Okay, that's good too.
To seek advice for their health, which is good.
So I know that GBMC has been very aggressive in stroke treatment and awareness, really.
Yes.
Talk about your role at GBMC.
Yeah, so I'm a general neurologist at GBMC, meaning I get to meet patients, diagnose and treat a wide array of neurologic issues at GBMC, including stroke.
I think we know what a stroke is, but really, how do you define it?
So, good question. A stroke essentially is loss of certain brain function due to loss of supply to the part of the brain that controls that function of the brain.
Caused by what typically?
Yeah, so good question. Really, there are two major types of stroke, and the way I like to explain it to my patients is we have stroke due to a blocked blood vessel and stroke due to a burst blood vessel. And the most common type of stroke by far is the stroke due to a blocked blood vessel, essentially meaning some sort of material. Can be a clot, can be plaque, cholesterol plaque, goes up to an artery that feeds part of the brain and blocks it off. And so whatever function that part of the brain controls is lost. And that's the symptom of the stroke that the
So when you're
patient
describing to anyone really, the different types of stroke, that's how you break it down for them.
Yes.
Now, I know it's common, but how common is it?
Unfortunately, it's pretty common. It's estimated, CDC estimates about 790,000 people in the U.S. Have a stroke every year. And unfortunately, it's the fifth leading cause of death in our country. So it's pretty common and pretty serious.
And it's possible, too, to have some sort of event that you might not even realize, too. So those numbers might not even be counted. Is that right?
Exactly. I mean, when we say strokes, we mean you've actually had a stroke. The other event you may be alluding to is called a TIA.
Yes.
Essentially, a transient ischemic attack is what that stands for. And essentially means that the stroke never quite took. So if it was a stroke to a blocked blood vessel, somehow the blockage was able to pass on, and then the function that was lost temporarily returns.
So you may have had a symptom or two.
Right.
And then it kind of subsided.
Exactly. And the mistake people make is just going to blow it off, or I'm well now, so it must be fine. But often that's really just a sign that something more serious is down the line.
So let's just be really clear right from the get-go. Don't ever blow it off. Is that right?
Don't. It's a very serious issue. Lots of people in our country still have strokes, so it's a serious thing and it should be taken seriously.
Okay, so while we're on that subject, so what do we look for? I mean, I think we have, at this stage in the game with the knowledge that we have about stroke, I mean, just the average layperson has some idea of what it might look like, but what are the big signs that we need to really pay attention to?
Right. So major signs and symptoms of stroke. Numbness on one side of your body, weakness in your face, arm, or leg. Other signs include, dizziness, loss of vision in one eye or both eyes, difficulty speaking, or difficulty understanding what people are saying to you. All of those may indicate that you or your loved one may be having a stroke.
Is it one side or the other? Does it matter?
It typically is one side or the other, but in less common cases, it can be both sides. Where you lose strength or sensation.
So we start having symptoms, multiple symptoms, or somebody notices a symptom we might not even notice that we're having, right?
Right.
The key here is time, right? It's all about time.
Right. We say, time is brain. If you are concerned you may be having a stroke or see signs of someone else having a stroke, really call 911. That's really key here, because don't take an extra aspirin. Don't try and
I was going to ask you that because I'm all about the aspirin.
Right.
Okay.
Yeah. I mean, don't take an extra aspirin. Don't try and wait it off. Don't think I'm just going to sleep it off and wake up in the morning and see what happens. Call 911 right away. Time is brain, and there are certain treatments that are time sensitive. So.
I think we should have a T-shirt that says "Time is brain."
Yes.
Do you have a T-shirt like that? You need one.
I need to make one.
Work on that.
Yes.
Okay, so can anyone get a stroke, or there are some people who are more prone or living a certain lifestyle that may contribute to that?
Right. So strokes can occur at any age. We know as we get older, strokes become more common. Age is a risk factor, but anyone at any age. And people at any age do have strokes, but there are certain risk factors, of course, that predispose.
But why is age a risk factor? Because we're getting heavier or not eating right or slowing down?
All of the above.
Okay.
Yeah, all of the above. And, and for some people, certain lifestyle choices or certain conditions, the longer we have them, the more, damage it does to the body, and all of those can accumulate into a stroke.
Do you think that young people are often fooled, that they don't even think for a second that they're having a stroke when they have very clear symptoms?
Right, yeah, it can be because, I'm young, it couldn't possibly happen, or I'm otherwise healthy, so it couldn't possibly happen. But, the way I see it, if you're having symptoms that seem like a stroke, you're concerned you may be having a stroke, just call 911, get checked out. It's very important.
It's hard to call 911. You know that, right? I mean, don't you think it's hard to call 911? Like your first tendency is to say, can I drive myself in? Can someone drive me? But you just said it just gets someone there as fast as possible.
Yes.
What kind of window do we have?
Right, so there's a certain medication, it's called TPA. Essentially, it's a clot busting medication. And this needs to be given within 4.5 hours of symptom onset, of when you begin to have your symptoms. So that's one of the reasons why time is so important. And of course, studies have shown that the sooner you can get treatment, whatever that treatment might be, the better, the more likely you have of recovering or of maximal recovery from that.
But are you hesitant to put an actual time on it? They always talk about the golden hour that
Right.
after a traumatic injury.
Yeah. I think it all goes back to that. The sooner you can get to a center, to a medical center, and get evaluated and begin the whole treatment protocol, the better it will be for you. We do know the time limit for that clot busting medication is 4.5 hours. So that's the hard limit for that certain treatment. But we know that if you can get it within an hour, even better, for
The
you.
outcome can be incredible
Yes.
if you can catch it soon
Exactly. The
enough.
sooner
You
the
talked
better.
about the numbers, which are really huge, and being at the fifth leading
Right.
cause of death in adults. So are we seeing more? Are we seeing less? Is it kind of holding steady? And why is that? Is it that our lifestyle is not improving enough, or
Yeah, so
or we're living longer?
I
Or?
think thankfully with things like this, awareness and better treatments, we are seeing a decline in some groups of people. But I think the big thing, of course, is that the numbers are still not great. I mean, number 5, 790,000 people in the U.S. every year. I mean, that's a lot. So clearly, we still have a lot of work to do. I still have a lot of work to do in educating my patients as to the signs and symptoms and the risk factors for strokes.
When you're out talking with people and you tell them what you do and you talk about stroke, is one of their first questions, should I be taking a low-dose aspirin every day?
Yes, that's a very common question. And of course, it's an individual decision based on your risk factors and what your health looks like, whether or not an aspirin is beneficial for you.
But what do you think most of the time?
I think if you're seeing me, you probably have neurologic issues, and especially if it's something like stroke or TI. And in that situation, you should be taking an aspirin unless you have some reason why you can't take it, like an allergy or something.
An allergy, or would it contribute to stomach upset, or is there a concern there? Or they're
Certainly.
pretty good about coding them now and it doesn't matter?
Right,
as
and
much?
there are ways around that, if it's a stomach upset type thing. But, if you have stroke risk factors and you need an aspirin, you should take one. Yeah.
All right, we talked in the beginning about how GBMC, we have a question. Should we take that first? I think we shall.
Several questions.
I love that. And by the way, I just want to give kudos to all the men who are in the audience today. I've never seen so many men here in the audience, so that's awesome.
Our first question is, how are cardiology and stroke related?
Yes, they're pretty.
How are cardiology and stroke related was the question.
Yeah, I think they go hand in hand because one of the common causes for stroke can be, a certain heart rhythm called atrial fibrillation, and that can predispose people, especially as we get older, to stroke. So in that situation, we often work with the cardiologist to find ways to control that rhythm, and so on and so forth. And of course, other cardiac reasons too. Why people may have strokes. In those kind of situations, working with a cardiologist is often to the patient's benefit.
Does blood pressure contribute?
Absolutely. So the major risk factors for stroke, high blood pressure is huge. High cholesterol is another big one. Obesity, diabetes, smoking, all those things, are all things that increase one's risk for strokes. Yes.
Another question? I'll repeat it. I think your mic is a little challenged.
Can sleep apnea cure blood pressure problems? And can we stop taking Plavix after a TIA in 2001?
Okay, that's a specific question. So twofold. Can sleep apnea contribute? Is that the question to cure?
Cure high blood pressure.
Oh, cure high blood pressure. And the second one, can this particular person who's asking the question stop taking Plavix? He's been on it, I'm assuming it's a he, since 2001.
Right. Well, let me tackle the first one. It's a good question. I think obstructive sleep apnea has been identified as one of those things that can, lead to cardiovascular issues and predispose one to strokes. For some people, their sleep apnea, we know that the body's response to apnea is to raise the blood pressure, so that can be part of the reason. For some people, maybe contributing to their issues. I think the only way to know for sure, of course, is to see a sleep physician, get your sleep apnea managed, and then see what happens to your blood pressure. And if you still need to be controlled, then of course there are things that one can still do: medication, diet, exercise that can reduce your blood pressure further. hope that answers that question. The next question was about the Plavix since TI in 2001. Well, I don't know the details of your medical history, so I don't know the reason why you're on it. Some people need to be on medications like Plavix and aspirin lifelong, and maybe that's where you fall into. If you have more questions, certainly talk to your primary care doctor about this, or come out and see a neurologist. And ask those questions. But good question.
Yeah, I think if you've been on something for so long, it's never a bad idea to kind of rethink it. And,
right, yeah. That's why I always say talk to your provider, especially about things like that before, and come to a consensus before, making a
Another
decision.
question?
Several more.
All right.
Is there such a thing as a mini stroke?
Yes, so I think people often, transient ischemic attack has many names. Some people call it mini stroke, but essentially it's the same thing. And
The TIA.
Right, and that essentially means that once again you had symptoms of a stroke, but then those symptoms passed and you went back to normal, usually a couple of minutes after the onset of symptoms.
Let me ask you this. I think and we're going to be talking about heart disease soon, but if you're trying to identify a heart attack, it usually means, I think, that there has been some sort of damage to the heart.
Right.
Right? So is a stroke some sort of damage to the brain?
Exactly.
Okay.
Exactly.
So a TIA means you avoided the damage, you've just had symptoms.
Right, much like the name implies, transient, it was short, it passed, ischemic, so loss of blood flow, and attack. So another name for stroke is called brain attack, much like we have a heart attack, we have a brain attack. That's another, term for stroke. So, essentially just means your symptoms passed transiently without giving you any significant, damage to the brain, and you've come back to normal. And that's what we call a transient
if you've
ischemic
had the
attack.
TIA, are you more prone then for stroke?
Yes, a TIA essentially is your body telling you you're probably right on the precipice of having an actual true stroke, and it's really a reason to be concerned and to seek medical attention. Coming to a neurologist, talking to your primary care doctor about those things. Don't ignore a TIA.
Does the type of stroke dictate the treatment? For example, if you have the type that bursts the blood vessel, wouldn't TPA cause more bleeding?
Yes, good question. 85% of all strokes are usually the blocked blood vessel. And, that's why a lot of my discussion will be geared towards that. The other less common, type of stroke is the burst blood vessel, essentially where blood vessel bursts and blood pours into the brain. In that situation, as clearly identified, we wouldn't want to give you a clot busting medication for that. Usually we try and control your blood pressure. Some people may need surgery to take that clot out of the brain, and so on and so forth. But those treatments are different from the blocked blood vessel.
Is one type easier to treat than another?
I wouldn't say that. I think they're both,
really?
Both complicated things. They're both very dangerous things. So we take a case-by-case basis and, sort of what this patient needs and what's best for them. All sort of high-level type medical decision-making to come about with the best outcome.
Another question?
Yes, ma'am. I'm 62, male with a demanding job. I eat healthy and exercise, but my memory and recall is not as good as it once was. What can I do to keep my memory intact?
Wow. Okay. So a little bit different from the stroke we're
It's
talking
a brain
about.
question.
It is a brain question indeed. So often we find that what I find in my clinic often is sleep. Sleep is a major factor in making sure your cognition is at its best. So that's often the first question I ask my patient. How is your sleep? Are you getting the 7-8 hours per night? Do you snore? When you wake up, do you feel tired? And if any of those questions are no, then you probably should see either your primary care doctor or your neurologist to talk some more about those issues.
Or make some lifestyle changes, which is another reason too, if you think you have sleep apnea, to try and get it treated if necessary.
Right.
More questions. This is a very curious group, and I like that.
Are you more likely to have a stroke when you get migraines?
Good question. So migraine has been shown to, very mildly, certainly not as strong as we see in high blood pressure and diabetes and smoking and high cholesterol. But there have been some studies out there that have shown a smaller increase in sort of, risk of stroke with people who have certain types of migraine headaches. But certainly is not the major, still by far the most Strong risk factors still are high blood pressure, diabetes, smoking, high cholesterol. All those things are much stronger than a migraine.
Last one for now. Besides stroke, what are other common neurological disorders in men?
Good question. So stroke, of course, is probably the most common one that I deal with. But other things too, depending on the patient's conditions, include nerve pain, low back pain, headaches, so on and so forth. Those are things that I see in my clinic.
And I don't know if we said, but are men, does this break down by gender? Are men more prone to stroke than women?
Yes, I would say so. For based on what I see, at least in my my practice.
So this is sort of an anecdotal evidence that you've seen.
Right. Yes, and I think studies have always shown that men too, sort of higher risk of cardiovascular diseases in men. So so that's why we, of course, so higher rates of high blood pressure, high cholesterol, smoking rates are generally higher in men, and all those things I think predisposes people to go on and have strokes.
So it's relatively new from what I've seen that, including GBMC, but hospitals are really kind of taking a more aggressive stance on stroke treatment, and they're making sure that everybody, particularly in the ER, is well aware of how to react immediately because time is of the essence.
Right.
Can you talk about what GBMC is doing specifically when somebody comes in? I'm assuming they come into the ER, particularly if they've called 911, and it's possible they're having a stroke. What clicks into gear?
Yes, so I mean, there's a whole protocol and algorithm that we follow once a patient comes in. As soon as the patient comes in, either the person at triage or the nurse calls what we call essentially a stroke code, and the neurologist gets called right away to essentially to listen to this patient's case and to decide whether or not this truly might be a stroke or is a stroke, and then that leads us down the pathway of what the best treatment is for them. But the most important thing, I believe, at GBMC is that those first few minutes that patient walks in, reporting stroke-like symptoms, the neurologist is often alerted very quickly, and that's really the big difference that's made. And of course, we have imaging on site, and we have the ability to provide the clot-busting medication in our ER.
Is there any downside to giving the TPA, even if you're not 100% sure what's happening?
So often there's really very little downside. There is a small, very, very small risk, of bleeding in the brain.
So you have to know the patient's history before you do that.
You have to know exactly, and the more experienced the hands are, the more that you're in, which is the advantage of having a neurologist, to consult with. That reduces those risks. So.
Okay, now that we've got everybody freaked out and thinking, all aware of their symptoms, there's life after a stroke.
Yes.
I mean, I think that's important to note too.
Yes.
And what goes into recovering?
Right. So often with stroke recovery, it entails usually, first of all, understanding what caused the stroke, and then getting the person who's experienced the stroke on the right types of medications, therapy, lifestyle changes to reduce the risk of that stroke happening again. And then once all of that is set into stone and everyone has an understanding of what's going on, then of course our therapists are invaluable. The speech therapist who often evaluates the swallowing of the patient and optimizes that. And then we have our physical and occupational therapists who are very important in getting the person back on their feet, getting them to using their limbs as much as possible. We know that the more therapy one can get in those first few weeks after a stroke, that really dictates how well they recover, years down the line.
Yeah, I was going to say, so once the stroke happens, there's not like a recovery period, right? You can immediately go into rehabilitation?
Yes. Typically, unless, there's some situations where that's not the case, but by and large, I would say over 90% of cases, once you're stabilized and we have a plan for how to prevent this stroke, usually rehab is the next most important thing for the patient.
That's fascinating. Thank you, Dr. Tosin Thompson,
Yes.
neurologist. They say the brain's the final frontier, right? Mm-hmm. So I'm glad you're out there staking it out for us and telling us all about how we can, I think my mic is going in and out a little bit, how we can look for symptoms of stroke, avoid stroke, and then what can possibly happen afterwards, and that there is a lot of hope.
Right.
So thank you for joining us. And our next victim is coming on down now out of the audience. It's just like The Price is Right. We're going to be talking about cancer. And we're going to be talking about heart disease soon too, which I know you're very closely related to. So thank you for being with us.
for
So
having me.
coming now on Greater Living is, you can give him a big hand.
Thank you.
See, this is a piece of cake, right? And happy Father's Day. Oh, by the way, new dad right here.
Thank you, thank you, thank you.
Dr. Ari Ellman is joining us now, and he is a hematologist and medical oncologist at the Sandra Malcolm Berman Cancer Institute, of course, GBMC Health Partners. Dr. Ellman, thank you. Come on down. See, we're just switching them all out, right? Thanks. And you have notes? Love that.
Notes.
So I'm trying to ask you something that's not on here.
Sure.
You were worried I was going to trip you up. So, okay, let's just start from the beginning and something easy and just explain your overall, because cancer is such a big, broad topic,
Sure.
right? So how do we kind of narrow that down, and what is your role
Sure.
at GBMC?
So I'm a hematologist and medical oncologist. Traditionally, those two fields have gone together based on the training. So hematology means a blood doctor. Sometimes that's for a blood cancer, such as leukemia or lymphoma. Sometimes that's for a non-cancer diagnosis, such as anemia, low blood counts, or low platelets, or for blood clotting issues or bleeding issues. The medical oncology side is...
Just looking at your picture back there.
Oh,
There you are. It's
great.
a nice one.
Thank you. The medical oncology side is where we treat cancers. As a medical oncologist, I treat cancers with medications, and traditionally that's been chemotherapy, but nowadays we use a lot of other exciting things such as hormone therapy, immunotherapy,
We're going
and
to
other
talk about all of
medications.
that, yeah. But broadly, I was just wondering, blood cancers, we understand, I think, as a society, many cancers. Colon cancer, we get that, breast cancer. Blood cancer is one of those that it's just really hard for us to pin down on how you find it, what are our symptoms, how many different types there are, and I'm sure it's like...
Sure. Literally, there are scores of them. They all kind of present differently. Depending on the type. Some can be very aggressive, and some could be what we call indolent or very slow growing. Sometimes people come in with fatigue, they're just feeling a little bit tired, but sometimes you can have the same symptoms as other types of tumors, such as lung cancer or colon cancer, meaning weight loss, night sweats, and certain types of lymphomas. Sometimes people just have this feeling they just don't feel right. They go to see their primary care doctor and they get a blood test. Just looking at their blood counts, and their blood counts just don't look right, and they refer to,
That's the first
someone
sign.
like us.
More common in the type of cancer you see, more common with men or women, or doesn't matter?
So cancer in general, unfortunately, guys, is more common in men than it is in women. That's not to say that women are not drastically affected, of course, by cancer. But men, statistics show that it's about almost a 50% chance, 1 in 2 in the course of a lifetime, that a man may be diagnosed with cancer. Women, about 1 in 3 over the course of a lifetime.
I didn't realize it was that high, actually.
According to some statistics.
Wow.
Men also, other statistics say that men have about a 20% risk greater than women, so depending on who you look at, but it's pretty universally agreed that men do have a higher incidence of cancer and more likely to die from cancer than women in their lifetime.
Now, we've talked a lot about risk factors, so I'm guessing that you're going to kind of repeat the same ones, right, for men specifically?
Absolutely. Well, the things that we can affect the most, smoking is obviously the big one that everyone thinks about, but a lot of that's been kind of beaten into us already, and I don't think there's anybody out there that says smoking is good for you anymore nowadays. And
And vaping, we don't know, right?
Well, vaping, we don't know, but there's starting to be some increasing evidence that vaping is not so good for us. That's a whole nother topic we can explore as well. Vaping, it may be good for people who are current smokers to help them smoke. There was a study in the New England Journal of Medicine
quit smoking, right?
to help them quit smoking that came out in January that showed that current smokers, they were twice as likely to quit by using vaping versus other methods that we have nowadays. However, on the scarier side, a more alarming side, a study came out in JAMA in February that showed that children or tweens or teens that are vaping are 4 times more likely to pick up smoking if they start with vaping. So it's almost a gateway to smoking.
You talked about the death rate for men in particular, and not to completely berate men this whole hour, but
Right.
is that because they're ignoring their symptoms and coming in too late?
Some of it might be that. Historically, a lot of it's been because of smoking, because men were much more likely to be smokers than women historically. Nowadays, the smoking rate for men has gone down, while that of women since the 1940s and 50s has actually gone up. Now, thankfully, they both seem to be going down, but that also helped men have a higher cancer risk. Historically, prostate cancer is much more common, obviously, in men and not in all in women. And prostate cancer, as Dr. Baronis said earlier today, 80% of men by age 80 will have some prostate cancer cells. Now, that doesn't mean that they're going to have aggressive prostate cancer, but it does qualify as the diagnosis. There's also new research looking at the actual genetics of cancer, and researchers at Harvard have shown that that women may have extra cancer protective genes that men don't have. So that may also help to lead to the lower rates of cancer in women compared to men.
We have a question, John, so I won't leave you hanging too long. Would you like to, oh, we're going to get it right from the audience.
Okay. Hi, doctor.
Hi. Thank
Over the
you for
last
coming.
several years, I was diagnosed with two blood conditions. One is called polycythemia vera, and the other is a higher than normal range of platelets. My question about polycythemia vera, I've been treated by a doctor of your nature at GBMC for a number of years, is what is can you identify any source of that particular blood condition? And if so, what does the prospects for the future look like in terms of changes in treatment, if any? For me, it's all asymptomatic, totally asymptomatic for at least 5 or 10 years.
Sure. So polycythemia vera is a condition that a mutation occurs in the bone marrow, in the blood cells that are making red blood cells and often platelets, and it leads to counts that are higher than our counts should be. So when someone has a very high red blood cell count, sometimes that can lead to thickening of the blood and increase the risk for stroke, heart attack. If it high platelet counts as well, those platelets are the cells that help for blood clotting and also increase the risk of blood clots. So the treatment for those conditions is really focused on lowering the blood count, and oftentimes we don't need to treat them earlier on, especially if patients don't have risk factors for those things. But it sounds like that you're doing well and you don't have any symptoms or risk factors, and you're just being followed with what we call watchful waiting.
That's more or less true.
He's doing well because he comes to all of our shows.
Great.
He's our number one
And he comes
fan.
to our practice, so he's in good hands.
Be my doctor, because the doctor I use now is leaving.
I
All
would
right,
love
well,
to
here
see
you go. Here you go. Sign up while you're here. You were talking about the treatments, and of course, with research and the growth in healthcare and technology, I'm sure there's so many choices for you. When you look at, I'm sure it's so individual. You look at one patient, and you have to come up with this whole kind of plan. I want to say cocktail because that's what they sometimes say for chemotherapy, but there's all kinds of immunotherapy. And can you just break down the main treatments for the types of cancer that you see?
Sure. So as I mentioned before, as a medical oncologist, I use medications, but that doesn't mean that that my patients are being exclusively treated by me. Treating cancer in 2019, it's not a one man or one woman show anymore. And we actually at GBMC have multiple tumor boards, which I think is unique to community hospitals. We have a breast and general tumor board on Tuesdays. Every week we have a head and neck tumor board every Wednesday, which I attend. We have a GI, gastrointestinal cancer tumor board on Thursdays, and we have a lung one Wednesday afternoons. And in those tumor boards, the specialists that treat each type of cancer come. So myself and my medical oncology colleagues come, the radiation oncologists come, the surgeons, if we're talking about a colon cancer, then the colorectal surgeons, for lung cancer, then the thoracic surgeons. And not just the physicians, it's also important we have multidisciplinary teams with nurses, social workers, survivorship, palliative care. All of us together help basically decide what the cocktail of treatment is going to be for any individual
And it's
patient.
literally, they call it a tumor board because it's like a board meeting. All the brains get
We
together.
try to be a little more efficient.
But it's a great way to communicate.
Absolutely.
And to take the best of everyone's expertise and kind of work it and figure out the best plan.
Absolutely.
So, okay, before we get to that question, so we have the tumor board. So then let's say decisions are made about radiation, chemotherapy, immunotherapy, which I'm not as familiar with, and I think most people are not as familiar with. Is there anything else I'm leaving out? Those are the big kind of, other than medication?
Right. So it's usually chemotherapy or immunotherapy,
Right.
hormone therapy, which is
Is that the
from
same
us.
thing?
So those are all different. So let's talk. We could talk about that
Okay.
now. Actually, it's a good time to talk about. So chemotherapy, everyone knows what that is. For better or worse, chemotherapy is, for lack of a better term, a poison. It poisons the cancer cells more than it poisons the healthy cells. But the side effects come from also poisoning the normal parts of the human body, and we've been looking for years for something better. So immunotherapy is something that's been brand new over the last few years, and the indications for immunotherapy are actually increasing by the day for different types of cancers. So when I talk about how immunotherapy, how it works and the side effects, I always like telling this story from one of my mentors at University of Maryland, Ashkan Ahmadi. So he's an Iranian-American leukemia specialist at University of Maryland. And when he was teaching us about immunotherapy, he said, Ari, why did your mother not kill you when you were in her womb? And I kind of like looked at the same look you're all giving me now is the look we gave him. And it wasn't an abortion comment. It was saying, when a child's in its mother's womb, the child is made up half of the mother's genetic material and half of the father. So really the child is its own unique genetic material, and the mother's immune system should look at the child as foreign and then attack the child. But there's a reason why that doesn't happen, and we didn't really understand that until the mid-1990s or so through research that was done at MD Anderson and actually won the Nobel Prize for medicine in 2018, that there are certain molecules on the cells called immune checkpoints. And those checkpoints, and the immune system encounters them, it tells the immune system, back off, don't attack me. So once they discovered that with a fetus, with children, they then looked at cancer, and there's certain cancers actually, such as melanoma was the first one they looked at, and also lung cancer and kidney cancer and others that express increased levels of these markers on them. So when we give these drugs to help block these markers or immune checkpoints, it kind of awakens the immune system to then go and attack the cancers. So that's also important to know, not just because it's interesting, but also because of the side effects of these drugs. So the side effects occur when the immune system can not just attack the cancer, but might also go and attack the normal parts of the body.
So would you, in some cases, have chemotherapy going with immunotherapy? And that seems like a lot for a body to take.
It is a lot. So when immunotherapy first came out, it was just used by itself, and in certain diseases it still is used by itself. But as we've gotten more experience with them and more studies have come out, there are certain cases, for instance, for lung cancer now first line, if a person is strong enough and robust enough, sometimes we will use chemotherapy and immunotherapy together because it's been shown to increase survival relative to either one of them by itself.
John?
Hey, great. I have.
Since you're waving the question mark over there.
I got 3 separate questions. So, Dr. Elmo, you're doing great, by the way.
Thank you.
Just want to let
I'll
you.
be the judge of that.
So here's the question.
My mother's watching, so I'll find out later.
In your experience in medicine as a medical oncologist, here's the question. Can cancer diagnosis be a precursor to potential stroke onset? Now, I know that doves into a little bit of the expertise of our previous guest,
Sure.
but can you answer that question?
It can, because we know that having cancer, especially certain cancers, particularly pancreatic cancer and sometimes colon cancer, can increase the risk of blood clots. So any condition that causes what we call a hypercoagulable state, or a condition that makes you more likely to form blood clots, that can also predispose to developing stroke.
I got 2 more questions. This question is from a member of our audience. I have polycystic kidney disease and had a 12-pound kidney removed after finding a tumor on it. Does kidney disease lead to cancer?
To be honest, polycystic kidney disease I'm not quite certain about, but kidney disease in general I don't believe increases the risk for kidney cancer. Kidney cancer, there are some hereditary conditions that can be tied to it. Smoking is certainly related to kidney cancer, but as far as I'm aware, I don't believe that it's related to developing kidney cancer.
And the last question I have here, stem cell research has been known to be able to help fight against some forms of cancer. Will there be more research done to fight against other types, or is the research being stopped or
I was
prevented?
going to say this is
That's a
can be
loaded political question.
yes. But important. Important.
I honestly don't know the answer to that on the political or medical side. I know that stem cells is a very important part of scientific research, and we're always looking at ways to obtain stem cells
I think
without
maybe
the ethical concerns.
Also, so let's try and take the politics out of it, but if stem cell research was somehow halted, would we stagnate some of the forward motion that we've made in treating cancers?
Well, I'm sure that there will be some treatments maybe that would not then be developed, but there's so many approaches and so many different vulnerabilities that we're trying to find in different
You'd
types
find a
of
way
cancers
maybe around that.
hopefully there would be other
And what
methods
is
to
to
treat.
you in this line of work the most exciting thing on the forefront that is being researched and studied as far as treatment?
I'd say immunotherapy that we spoke about. We see responses with immunotherapy that we've never seen before, Mary Beth. There's, my favorite example is a patient of mine who's she's 82 years old, and she was diagnosed with a terrible lung cancer, really metastatic everywhere in her body. And we put her on immunotherapy and actually chemotherapy at the same time because she chose to be more aggressive. Even though a lot of times in that case I would only use immunotherapy by itself, just due to her age and how how poorly she felt. She had a anniversary coming up, her 65th wedding anniversary, 60th wedding anniversary. She got married when she was 17. 60th wedding anniversary was coming up in a few months, and she asked me if she was going to make it, and I couldn't answer that question at that time. But we put her on the immunotherapy and chemotherapy together, and it's over a year later now, and she has no sign of disease.
That's
and it's
incredible.
It's really a miracle. That's
Wow.
what I tell her.
I wish she was here. I'd love to
celebrated
hug
the
her.
anniversary. She had her anniversary.
Great.
So that's I don't want to say that's the normal response.
But why did she respond so
that's
well?
what we're trying to figure out. That's why it's so exciting about this. That these responses they didn't exist before the era of immunotherapy. You would never see such a miraculous response with chemotherapy like that. Still, it only occurs in, I'd say, 5% or less of patients. But the fact that we see that gives us hope that eventually we can figure out what it is that's making her respond and channel that to other patients.
And then my next question is, when you talked about the side effects, especially when you described what immunotherapy does, how did she at her age handle that?
So the side effects, it's hard to predict who's going to get what, actually. It can attack any organ. I mentioned that the immune system can then attack any organ.
Is it random?
So it feels kind of random, because sometimes I have patients that are on immunotherapy without any problems, and then all of a sudden 6 months later they'll develop diarrhea due to colitis, which is the immune system attacking the colon, or they'll develop pneumonitis, which is shortness of breath or cough due to the immune system attacking the lungs. It feels random to us because we don't fully yet understand the tools that we're working with, but hopefully one day through further research we'll be able to figure out how to predict these things and prevent them.
And then when you do the immunotherapy and you stop it, you've done the course, is it still working to attack potentially the body?
That's actually a fantastic question. There is research actually now published. Actually, a friend of mine at the FDA, Dr. Hannah Weinstock, published a paper recently that patients who have side effects are actually more likely sometimes to have responses, and sometimes patients, I've seen this with my own eyes with a kidney cancer and a lung cancer, who've had to stop therapy due to a side effect, have continued to respond being off of all therapy. I had a patient with kidney cancer that had a bad rash, and we had to stop the immunotherapy, and he was off therapy for 9 months, and every 3 months we got a scan, and the cancer still got smaller and smaller with each scan, because the immune system was still working.
So it may have a residual effect that
Correct.
you just have to watch and see. It's incredible.
Yep.
So this is a question I hate, but it's important because it's practical.
Sure.
I've known people with debilitating diseases, chronic diseases, and it's a financial burden in many cases. So because immunotherapy is relatively new, how do insurance companies handle it? And are you incurring more cost as a patient to go? I mean, you're trying to weigh out.
Absolutely. As physicians, we always think about the physical side effects of therapy, but
Sure.
there's also financial toxicity, especially with the price of some of these drugs, which frankly is outrageous. Even we feel that way. For most immunotherapy mostly are drugs that are given intravenously or IV. typically we don't have difficulty getting insurance companies or Medicare to cover those drugs, and it hasn't been as much of an issue. Where we're really running into some issues are with the oral medications. A lot of cancer drugs nowadays are given in oral medications, in oral form, which theoretically is much better for patients because they don't have to come in for IV infusions, but for Medicare patients especially, it's paid out of a totally different basket, and some patients, if they don't have good drug coverage, can have up to 20% copays. When you're talking about some drugs that we use can literally cost $1,000 per pill, which is, again, outrageous. Please call your congressmen and senators after this show. Then
I mean, that's...
yeah, and nobody can afford that, really.
Right.
So, but immunotherapy, thankfully,
But then you're
you're
literally making a choice at that point. Do I want to try and live?
Well, that
Or do I
is
want to
true.
drive
Thankfully, we
sell
have,
my house?
It's absolutely true, and I can't say that people hasn't gone through their minds. We at GBMC don't let that happen to people. There's nobody that's going to have to make that decision. We have excellent oncology support services that will help patients, work with patients, find financial resources for them, either through the drug companies themselves, through grants, through certain societies, for instance, the Leukemia and Lymphoma Society, and help them.
Help and support.
They wouldn't have to make that decision.
Right. I would think as the type of doctor that you are, because every patient is so specific, that you would really remember each individual nuance to their diagnosis and their treatment.
We try to. Every person obviously is very different, and something I always keep in mind is that even if something is routine for me, it's never routine for my patients. When someone comes in with a new cancer diagnosis, I know that that's the scariest day of their lives when they're coming in to talk to me. So even though it might be the third person that day that I've seen with a new diagnosis, I always try to keep that in mind, and each person look at them individually.
I'm told that you had a big weekend last weekend at GBMC. Is that correct?
We did. We had our annual survivorship event on Sunday. It was the biggest one ever. We had 530 attendees.
Yay!
At Martins Valley Mansion, and that was cancer survivors, their families, the Cancer Center staff. It was an inspiring, powerful, moving day, hearing stories from survivors about their journeys.
If for nothing else, that's why you do what you do, right?
100%. Absolutely.
How are you celebrating Father's Day?
So this Father's Day, I'm doing something a little, I guess, crazier than most people do.
Okay.
So one of the reasons I became an oncologist early on, my college roommate, he was a cancer survivor, a childhood cancer survivor. He had a sarcoma. And he got me involved with an organization called High Lifeline, which originally started with camps for children with cancer, and now is involved with all aspects of helping children and their families dealing with life-threatening illness. So last year they had something called Over the Edge, and I'm doing it again this year, rappelling down a 25-story building in downtown Baltimore.
Get out.
So this is me doing it last year. I swore when I got to the bottom I would never do it again, but through some arm twisting, and I'm also the incoming chairman of the board of the Mid-Atlantic region for High Lifeline, I'm doing it again for the kids. So that's what I'm doing this Sunday. That's my family.
Oh, it's a great
I didn't
picture.
finish my plug yet. So if you'd like to donate, I'm only 2/3 of the way there. The donate link is Elman. It's my last name.
Write it down.
ELMAN.family/OTE. That stands for Over the Edge. And even $5, even
We'll
a
post the
dollar,
link.
anything would be helpful. And that was my family. That's the other reason I do what I do. 5 young ones. That picture's 2 years old, but that's the last time we got them all to smile together.
Okay, so if I did that, I would have to have Dr. Thompson there standing by, because I think I would give me a stroke.
Right.
So I just have to talk about what that was like, hanging over the edge, and did they have to push you?
I did not look down. I just looked straight ahead, and you kind of just walk down the building. There's 2 harnesses, so I know in my head nothing bad was going to happen. But I was the last one to go last year, and it was poor weather last year, and it was raining, and I was kind of swinging. And
Oh my God.
And they shut it down. As soon as I got to the bottom, they shut it down. So
Dr. Ullman, people are counting on you. I don't think
I know.
there's some nervous patients you have that are watching right now. They're like, oh, I don't
Hopefully
think you should
we'll
go
have
over
better
that
weather
building.
this year.
All right, I hope so too. Thank you so much for joining
Thank you so
us
much,
today.
Mary Beth. It was a pleasure.
And talking about what you do and providing hope
Thank you.
for the future. Yay! Okay, speaking of heart attacks, Dr. Joe Fiscaldo is here. coming on down. Thanks for waiting in the green room. You're not the heart attack. That was the heart attack, that going over the building. You're here to prevent the heart attack.
Absolutely.
Right? All right. So heart disease is kind of the last thing we're going to be talking about. We're talking about men's health. And of course, we're going to be talking about cholesterol. But Dr. Fiscaldo is the Medical Director of Clinical Quality, Faculty Department of Internal Medicine. So you're overseeing a lot of this, right?
Hopefully,
Yeah.
We have a lot of fun teaching the residents and also taking care of patients.
And so is that basically the cardiology department, or just, it sounds very all-encompassing?
It's a confusing name, but general internal medicine, we do a little bit of everything, sort of head to toe, all kinds of different illnesses that we take care of and treat.
Okay. So we're going to focus on the heart. Is that kind of your forte? Is that fair to say?
It's one of the things
Is that where you
that I
came,
enjoy.
kind of cardiology, is that?
And I enjoy, I'm not a cardiologist, but I enjoy preventive medicine and trying to prevent disease. We see lots of people that have unfortunately done some damage to their bodies over the years, and my goal is to catch people early enough that we're going to prevent some of these things.
Why are we not living healthier lifestyles? I think we all know at this point, right? Like, we don't smoke, we have to exercise, and we have to eat relatively well. But it's hard for us to do it in general, and as I'm hearing, it seems to be harder for men.
Men are worse, or the worst, but...
Men are the worst. How many times have I said that?
I think I've heard that at home, but we all, it's partly human nature. You know, we don't want to do things that we are going to, that are going to take a long time to prevent a disease. It takes a lot of these things that we talk about really take time, and it's human nature to want to be able to fix something fast, and it's more exciting to be able to do that. And lots of medicine today, we hear in the headlines about things in cool treatments, but really a lot of the stuff that we should be doing is preventing disease in the first place. It's not as exciting, it's not as...
Except that we're all living longer, and we all, this generation, I think, everyone in this room wants to live a more active lifestyle than we saw our parents or grandparents live. They were more accepting, I think, of the aging process. We want to keep active and keep healthy, and it's all about preserving your health, but yet we're still not really making the steps that we need to take to change the course of what's happening with these diseases. They're still on the rise.
Right.
Except for, I'm guessing, is lung cancer dropping because of the smoking drop, or we haven't seen that correlate yet?
There have been some decreases in certain areas in certain cancers.
Okay,
yes.
because of that.
But yeah, we're not very good at we're a nation of couch potatoes still, unfortunately.
All right, cholesterol. We've all heard of it. People are always still confused about what's the good cholesterol, what's the bad cholesterol, what do these numbers mean? And now we talk about inflammation too. There are other kind of readings you can get to. So let's have a basic course in Cholesterol 101.
Sure, there's lots of confusion surrounding cholesterol, but the neat thing about cholesterol, everybody has it, but it's a molecule that's in our body that we all need because it's important for our cell structure, cell membranes. It's important. We need some, but most Americans have way more than we need. This particular molecule is produced two different ways. We either can eat it, consume it, and particularly foods that are high in fats usually have cholesterol, animal fats, and we take it in and absorb it that way, or our body can make it by putting together smaller molecules. Usually, though, too much is bad, as most of us know.